Great. Thank you. I mean, I'm amazed by the previous two sessions and the information that and also the lessons I've learned from both professors. And here I mean, my journey with Ritival started I would say, when I moved to the View Hospital, where we set up a new service. And working back in the UK, where we used to have cover for electroretinography. Moving to a new place, setting up a new service, I was concerned about not being able to refer patients, knowing that they used to have long waiting times until the conventional ERG, is done. And for this reason, the one of the thoughts were about bringing the portable ERG. And thanks for Retival for the invitation to take part in this, and also for having incorporated such a service that is helping us on a daily basis. Multiple applications for ERG, as you've seen in the first, two presentations, in pediatric conditions, in congenital diseases, in cases where unexplained vision loss is there, vascular disorders of the retina, and optic nerve problems. Anything in medicine is about early assessment, so early detection, so monitoring the progression, uh, uh, also predicting the progression and the treatment follow-up. So this will cover the need of the specialist as well as the need of the patient. Now, in my routine practice, I was thinking about five major aspects. Number one, cases of unexplained vision loss. What shall I say to the patient? Cases where my diagnosis needs a bit of refinement. Preoperative planning for better prognostic value, especially for diabetics prior to vitrectomies, um, cataract, dense cataracts in diabetic patients, and also using ERG to plan for to go for a multifocal or a non-multifocal intraocular lens, as Prof. Chin showed us, and also to try to answer the questions when the structure doesn't mean the function. And if you incorporate all that into a medical retina practice, or a hybrid practice where you do MR and VR, you can see that there is a huge potential for diabetic retinopathy, diabetic maculopathy, vein occlusion cases, and also the planning for anti-VEGF and PRP therapy, pan-retinal photocoagulation. Um, and when it comes to the diabetic retinopathy, I have seen that Retival has improved my let's call it the quality of the consultation I'm having with the patient, because it gives me the ability to offer an objective assessment of the retinal function without the need for pupillary dilatation, especially in the presence of wide field fundus photography. It allows me for early detection of the retinal dysfunction that may precede the visible structural changes. I'm able to tell the patient that your function change is preceding the structural, and we need to plan something for you. And the ability to facilitate earlier intervention and also a more tailored treatment plan, and this is vital in those cases. And also the provision of a true physiological measurement of retinal function, as opposed to subjective tests like visual acuity, or even visual acuity or other tests. So you're talking about the function, you're talking about something objective, and you're becoming more proactive. I'm not going to go into the RG waveform build, but I think it's an amazing, and I think you will be able to see it as part of the recording. It talks about the A wave, from where it's coming, the B wave, and other waves. But I'll move to the first case. This is a female of 38-year-old. She's got hearing loss since childhood. The parents are likely cousins. She's got five brothers, but no noteworthy findings. Two of the four children suffer from hearing problems. Long-standing history of night blindness dating back to childhood. She came for a second opinion. Good, best corrected visual acuity. It's mainly peripheral rather than central, and no prior treatment. This is the wide field fundus photography of her, the color picture, and this is the autofluorescence one, where you can see typical changes. We did the light adapted and the dark adapted cases, and we found that both of them are abnormal. So we've got an abnormal cone function and also an abnormal rod function, as you can see in the ERG highlighted here. And based on those structural, anamnestic, and ERG findings, I suspect Usher. Now, if I were in a practice where I don't have an ERG, most probably this patient would have come to me for a second opinion, and I would have told her, listen, I still have to do an ERG, and and I would have possibly trying to reach a conventional ERG center, which would take time. So one benefit in case one is that you have early access to something portable, something that you have, and so you can give patients more clue about what's going on. And the next step would be the family screening and the genetic counseling. Oh, this is another case where possibly the features of the congenital problem are not that typical. A female, 50-year-old, myopic, complained about vision loss, but she always attributed that vision loss to myopia. And as you can see, the vision in the right eye is 0.9, while in the left eye is 0.5. Unfortunately, this lady had refractive laser in the past for the treatment of myopia, and that was, as per her, to ameliorate the burden of myopia. Now, if you look at the fundus images, you've got those typical changes, but they are circumscribed in the posterior pole. And when we do the OCT scan, we've got cystoid macular edema in the left eye, which is significant compared to the right eye, which is slightly minimal. So as you can see, you've got a case, and this is the ERG. And in the ERG, you've got the photopic and the photopic ERG, which revealed an abnormal cone function, and also the scotopic was abnormal. So in those cases of atypical retinitis pigmentosa, I mean, like let's go, like if we went back in history into a practice of a refractive suite where they have a portable ERG, this patient should have done an earlier ERG at that time, and this would have saved her the cost and risk of refractive laser. In addition to that, it would have given her much more information about her eye. Go back. This is very important in my practice. I work in an endemic area where diabetic retinopathy is endemic, possibly 1 out of 4, 1 out of 3 of my patients. Now, there is very important talk about the diabetic retinopathy score. And this score is a combination of 3 things. One coming from the pupillary reaction, one coming from the ERG itself, and one coming from the age of the patient. The nice thing about this, it does have a high sensitivity and a high specificity and a low failure rate to detect those patients who are going to progress. And as you can see in this trial, especially if you look at year 2, you can see that in year 2, for example, the risk of progression went above 50% when the ERG was abnormal. But if the ERG is normal, only 4%, as you can see within in the 2-year section, only 4% progress. So it does have a considerable value when it comes to detecting the progression, which means that I can plan treatment accordingly. A male of 46-year-old, proliferative diabetic retinopathy in the left and severe in the right, unaided vision is 0.8 and 1. The left eye had, as you can see, PRP in the past. The patient was not happy with the experience. He feels that it did not serve him, and he came to me for a second opinion because he was told that he's got changes in both eyes. I did an ERG on him, and I found that the right eye, which is the one that's having inferior ischemia, as you can see here, does have a better ERG compared to the left eye. Better ERG, I mean better what we call a DR scoring. So, and that helped me inform the patient that perhaps we can avoid doing PRP in the right eye, and most probably the ERG changes in the left eye are related to the previous laser. So I tried to go conservatively, help the patient with his treatment plan, and the patient remained treatment-free in the 2-year follow-up. Do not rush for PRP. Look at the function first. The last case is the best case I have ever utilized ERG for. A 72-year-old diabetic, diabetes, dementia, ex-ambassador with single eye patient, vision issues in the left eye, no light perception in the right, best corrected 0.2, has been everywhere. He wanted to see if his cataract can be done. The patient has got dementia, so the family is trying to push, but the family would like to say, when we do the cataract, will his vision improve? And I said, listen, I can't answer this question, but I have a retival and I'm going to use it. And when I did the ERG, I found that the amplitudes and the implicit times were borderline to normal, but were reassuring. So had we did not perform the ERG, I might have possibly told the patient that, it's very difficult to judge. I don't know what's going to happen. But the family with an ERG and myself, we went we went and we did the cataract. The patient vision improved to 0.7. Not only this, his dementia, his signs of dementia have improved because now he's got something that he's relying on and his interaction with people has improved. Last but not least, an unexpected vision drop after surgery. Patient with diabetes, meningioma, treated with radiation therapy and surgery, prior corneal transplant. So he was offered corneal transplant due to the recurrent herpetic keratitis. The corneal transplant did not improve vision. There was an impression that something wrong was with the optic nerve, but not that significant. So he came to me, nothing improved. I told him could be macular ischemia, optic neuropathy, or radiation induced. We did that and we found that the W ratio was lower in the left compared to the right, something that's suggesting an optic atrophy and something that's suggesting a supernormal ERG due to lack of inhibition. So it gave me a clue about the root cause. Finally, as you can see, broad range of pathologies can be detected. I think incorporating this into your practice is vital, and the interpretation requires training. But with time, you will see that it will improve the flow and it will improve the quality of the care that you're offering your patients. Thank you.